Welcome to the Emirates Society of Emergency Medicine Emergency Ultrasound Lecture Series. My name is Rasha Bouhmaid, and in this presentation we will be discussing first trimester pregnancy ultrasound. The objectives of this presentation include reviewing the indications for this study, relevant pelvic anatomy, the technique, the ultrasound findings. We will discuss important pitfalls and review the literature. Why do we care? We know that the complications of first trimester pregnancies are common. Miscarriage occur in 20 to 25% of all pregnancies. An ectopic pregnancy occur in 1.5 to 2% of all pregnancies and 8% of all pregnant ED patients. 40 to 50% of ectopic pregnancies have been misdiagnosed initially. Studies have shown that emergency physicians can accurately and rapidly use bedside ultrasound to detect an intrauterine pregnancy. The goal of first trimester pregnancy is to rule in the presence of intrauterine pregnancy and identify pelvic free fluid. Because heterotopic pregnancy is extremely rare in patients who have not undergone reproductive assistance, ectopic pregnancy can be ruled out with the presence of intrauterine pregnancy with a negative predictive value approaching 100%. Again, I want to emphasize that the goal of the first trimester pregnancy is to rule in the presence of an IUP. And therefore, ectopic pregnancy can be ruled out with the presence of IUP with a negative predictive value approaching 100%. It's important to understand the limitation of this. This is not applicable to patients who received fertility drugs or IVF. The incidence of heterotopic pregnancy is estimated to be 1 in 30,000 pregnancies. These are in low-risk patients. However, more recent data indicate that the rate is higher due to assisted reproduction, and it's approximated 1 in 7,000 overall, and it can be as high as 1 in 900 with ovulation induction. So what are the indications of performing a pelvic ultrasound? A bedside ultrasound should be considered in any patient with early pregnancy and symptoms of potential ectopic pregnancy, including pelvic pain, vaginal bleeding, or hypotension. We will review pelvic anatomy because that is important for you to understand the ultrasound images. The uterus is a pear-shaped located between the urinary bladder anteriorly and the colon posteriorly. In majority of women, the uterus is antiflexed. However, in 10% of patients, it is retroflex. The pouch of Douglas is the most dependent area in females. The fallopian tubes are rarely seen on ultrasound except when they are pathological, like hydrosalpinx or tubo-ovarian abscess. There are two approaches to performing the sonographic exam of an early pregnancy. There's a transabdominal and a transvaginal ultrasound. Usually, a transabdominal scan is done first while the patient still has a full bladder. The patient then can empty her bladder prior to transvaginal scan if the transabdominal scan was non-diagnostic for an IUP. In patients with an unclear gestational age, it is even more important to perform an abdominal scan first. Occasionally, a second trimester fetus will be visualized transabdominally, and a non-sterile pelvic exam, which would increase the risk of infection, can be avoided. So in this table, we just summarize the difference between a transabdominal and a transvaginal exam. The transabdominal exam is rapid, non-invasive. It has greater field view to evaluate overall structures, but it requires a full bladder. On the other hand, a transvaginal approach has better visualization of the pelvic organs, improved spatial resolution, and you can perform it with an empty bladder. In the UAE, almost all emergency physicians will be able to perform a transabdominal ultrasound. However, a transvaginal ultrasound is very limited, and therefore, the rest of the talk we will be focusing on the technique of performing a transabdominal ultrasound. You will use a low-frequency curvilinear probe to perform this exam. Like the suprapubic window used in the FAST exam, the transabdominal ultrasound for early pregnancy is easily performed with a full bladder. An inadequately filled bladder is one of the most common causes of technically inadequate transabdominal exam. There are two views that are necessary for this exam. There is a longitudinal view and a transvaginal view. At least two views are necessary for complete evaluation of the uterus, both demonstrating the endometrial stripe and the uterine content, if any. In the next few slides, we will discuss the technique in details. In the longitudinal plane, the indicator is placed to the patient's head, and you begin by placing the probe above the pubic symphysis. The ultrasound beam travels through the pelvic organ is representative in the diagram on the right. This is a diagrammatic as well as an ultrasound representation of the longitudinal view. You would see the first structure is the bladder, which is fluid filled. Track the vaginal stripe to the cervix and the endometrial stripes through the uterus. The pelvic structures are often not midline, and you must scan from right to left until the best plane showing the structure in the longitudinal section is found. Increase the depth to visualize the posterior uterus and the pouch of Douglas. In this video is a representation of how to perform a longitudinal view. You can see they start at midline, probe markers towards the patient's head, and then you fan right to left in order to interrogate the whole structure and find the midline. To perform the transverse view, rotate the probe 90 degrees so that the probe marker is at 9 o'clock or to the patient's right. The diagram on the right represents the ultrasound beam crossing through the pelvic organs. Again, this is a diagrammatic as well as an ultrasound representation of a transverse view. The first structure below the probe is the fluid-filled or urine-filled bladder. Scan through the uterus, cervix to the fundus. Do not focus on the gestation if it's visualized until the uterus has been systematically evaluated in both the longitudinal and transverse plane. And remember that bowel gas, body habitus, or an empty bladder may limit your view. In this video, we review how to perform a transverse view of the transabdominal ultrasound. Remember, panning superiorly and inferiorly in order to visualize the entire uterus. The goal of the ultrasound in a first trimester pregnancy is to identify a definitive IUP. What are the definitive signs of an intrauterine pregnancy? To be conservative and to practice with the greatest safety, only an intrauterine yolk sac, fetal pole, or intrauterine fetal heartbeat should be identified as signs of a definitive intrauterine pregnancy on a bedside ultrasound scan. Gestational sac is a circular structure with a thick echogenic rim surrounding a clear anechoic center, which represents an early chorionic cavity. A gestational sac can be an early marker of a normal gestation. It can also be the result of a hormonal stimulation caused by an ectopic pregnancy, known as a pseudo-gestational sac of ectopic pregnancy. This finding is seen up to 10 to 20% of all ectopic pregnancies. Therefore, it is not recommended to use this finding as a sign of a normal gestation. Another early gestational finding is a double decidual sign. The double decidual sign has also been described as a reliable marker for early intrauterine pregnancy. This is a sac with an echogenic and a hypoechoic ring surrounding it. However, even in the radiology and obstetrics literature, there is a debate as to the accuracy of this finding, and it is not present in all cases. Thus, before appearing of a yolk sac, an IUP should not be definitively diagnosed by a bedside emergency ultrasound. The first reliable sign of an IUP is a yolk sac, a sac within a sac. It's visible 6 to 7 weeks by transabdominal ultrasound. It's a small round black anechoic sac with a brighter wall, approximately 5 to 6 millimeter in size. A yolk sac measuring 8 millimeter or greater or calcified yolk sac is associated with fetal demise. The yolk sac regresses and disappears by 12 weeks. When first visible, the gestational sac contains no identifiable structures. By the time the diameter is about 5 to 8 millimeter, the yolk sac, which is the sac within the sac, should be detectable. In a normal fundal pregnancy, the embryo is located directly in the middle of the uterus and has a wide, usually greater than 1 centimeter, endomyometrial mantle distance. In a normal pregnancy centered within the uterus, this measurement should be greater than 0.8 centimeter. It is critical that we measure the thinnest wall in 2 planes to get a true sense of anatomical relationship in a 3D space to rule out an ectopic pregnancy. While a short axis view is the best for measuring the mantle's distance, clinicians should always examine in a long axis plane as well to fully investigate the width of the mantle. The second definitive sign of an IUP is a fetal pole. By the end of the 6th menstrual week, the mean diameter of the gestational sac grows by 1 millimeter per day. The yolk sac appears and embryonic cardiac activity may be seen between the yolk sac and a wall of chorionic sac, even before the embryo is measurable. At this point, the tiny embryo is surrounded by a small amniotic membrane. This complex, located between the yolk sac and the chorionic wall, is termed the fetal pole. It is usually visible at 7 weeks by a transabdominal ultrasound. The final definitive diagnosis of an IUP is the presence of an intrauterine heartbeat. The embryo grows by about 1 millimeter per day in crown rump length, and by the end of the 7th menstrual week, the embryo measures about 5 to 10 millimeter and should exhibit cardiac motion on both transvaginal and a transabdominal scan. Physicians must use an M mode to highlight the cardiac motion because it uses less acoustic power than Doppler and thus theoretically transmit less acoustic energy to the fetus. The alternating black and gray bands represent chamber movement. Heart rate is calculated by measuring one cycle length and determining the cycles per second based on the measurement. In addition, many bedside ultrasound machines will have an automated fetal heart rate calculator function in their M mode menu. In the next few slides, we will go through some ultrasound findings of an abnormal IUP. There are certain sonographic findings are consistent with abnormal IUP. First is the absence of a yolk sac in the setting of a mean sac diameter of greater than 10 millimeter. Second is the absence of a fetal pole or inability to visualize a fetal heartbeat with a mean sac diameter greater than 18 millimeter. Third is the gestational sac develops saggy or irregular internal margins. And finally, there is no fetal heartbeat seen with a fetal pole greater than 5 millimeter on a transvaginal ultrasound. So in this slide, we summarize all the ultrasound findings of an abnormal IUP. Let's go through some cases. Case number 1. This is a patient who comes in with pelvic pain and has a positive beta-hCG. Is there a definitive IUP based on this ultrasound? And the answer to that question is yes. So in this case, you can see that there is a yolk sac as well as a fetal pole, and both are definitive signs of an intrauterine pregnancy. It's another patient with pelvic pain and a positive beta-hCG. What do you think of this ultrasound scan? So this is a transabdominal ultrasound. It's a longitudinal view. You can also see signs of a definitive IUP, including a yolk sac and a fetal pole. So this is another case. A young female with pelvic pain had a positive urine beta-hCG. What do you think? Is there a definitive IUP? So based on this ultrasound, this is a transabdominal longitudinal view. What you can see here is small amount of free fluid in the sac, and you can see probably a gestational sac. I don't see any definitive evidence of a yolk sac or a fetal pole. So there is really no definitive sign of an intrauterine pregnancy. So approximately 20% of patients with positive beta-hCG will have an indeterminate or no definitive IUP with the following outcomes. Failure to identify a yolk sac and or a fetal pole in the uterus of a pregnant patient can signify different possibilities. It could be an early normal IUP, it could be an abnormally developing IUP, active or completed miscarriage, or ectopic pregnancy. If the patient is otherwise stable after a radiology performed ultrasound, They can be managed expectantly with an outpatient follow-up by a gynecologist with serial beta-hCG and a repeat ultrasound. Another area of much confusion and debate is the correlation of serum hCG levels with ultrasound findings. The first important rule for the emergency physician is that there is no level of hCG which a patient can be ruled out of ectopic pregnancy. Ectopic pregnancy have been described with levels less than 30 and very frequently less than 1000. Therefore, pelvic sonography should be done for any patient who is pregnant and you are suspecting an ectopic pregnancy regardless of the beta-hCG level. The concept of discriminatory zone becomes more significant after a pelvic sonography is completed. The discriminatory zone is the level of beta-hCG which an intrauterine pregnancy should be seen 100% of the time. The transvaginal and transabdominal ultrasound have different values. In a transvaginal ultrasound, you're able to visualize an intrauterine pregnancy earlier with a discriminatory zone of 1500. However, in a transabdominal ultrasound, the discriminatory zone is anywhere between 4000 to 6500 because it uses a lower frequency probe and therefore the images with less resolution. If an ultrasound is indeterminate and the serum beta-hCG above the discriminatory zone, the suspicion for ectopic pregnancy should be increased. However, serum beta-hCG are mostly helpful in following a patient over time, and there is no level of which a patient will not require an ultrasound except if it is 0. There are a number of algorithms that have been developed to correlate sonographic findings and beta-hCG levels to improve diagnostic accuracy and clinical consistency. This was taken from the Manual of Emergency and Critical Care Ultrasound. There are several variations of the algorithm, although the recommendations are generally similar. So back to the case. This patient came in with a pelvic pain and had a positive urine hCG. We performed a transabdominal ultrasound, and this is what you see. Small amount of fluid in the Yolk Sac and not really a definitive IUP. So what would you do? A transvaginal ultrasound was ordered, and this is the image obtained. You can see that this patient had a Yolk Sac that was identified with a transvaginal ultrasound. This is an important point to emphasize that sometimes the transabdominal ultrasound might not be as accurate as a transvaginal ultrasound because the transabdominal ultrasound uses a low frequency probe, therefore the image resolution can be inadequate. So if your transabdominal ultrasound is inconclusive, you need to get the transvaginal ultrasound to confirm an IUP. So this is another case. A female comes in with pelvic pain and a positive hCG. The patient is hypotensive in the emergency department. You perform a bedside ultrasound, and this is what you see. Is there a definitive IUP? The answer to that question is no. Let me freeze a still image of that video. So here you can see the bladder anterior to the uterus, and there is free fluid in Yolk Sac. In patient who is hypotensive, there is increased suspicion that this patient could be having an ectopic pregnancy. Our goal is to diagnose an IUP and not really find the ectopic pregnancy. Therefore, if you don't see an IUP, you're highly suspicious for an ectopic pregnancy. And in patient who is hemodynamically unstable, that means a stat consult for a gynecologist. Let me play the video again. And try and concentrate on the uterus after it disappears. I'm going to freeze the image that I'm interested in. And here you can see a circular structure, but it's not in the middle of the uterus. This will increase my suspicion that this patient could have an ectopic pregnancy. Even if I did not see that and I just see that there is no definitive IUP and some free fluid in the sac, my suspicion for an ectopic pregnancy is very high. So if you're suspicious for an ectopic pregnancy, another area you should evaluate to look for free fluid is the right upper quadrant and the left upper quadrant ultrasound. This is the same views you obtain when you perform a FAST exam. And in this patient, you can see that both views, the right upper quadrant has some free fluid at the inferior pole of the kidney, as well as the left upper quadrant has some free fluid in the subdiaphragmatic area. So, when you find free fluid in Morrison's pouch, by bedside ultrasound, it predicts the need for operative intervention in suspected ectopic pregnancy. And this study was published in the Annals of Emergency Medicine in 2007. So putting the case together, this is a young female with pelvic pain with a positive BhcG who's hemodynamically unstable. You perform a bedside ultrasound and there's no definitive sign of IUP with evidence of free fluid in the right upper quadrant, left upper quadrant, as well as the pelvic view. This increases your suspicion of a ruptured ectopic pregnancy and warrants getting a stat gynecological consult. There are a number of protocols that have been developed to help you incorporate the pelvic ultrasound findings into the care of patients with possible ectopic pregnancy. So let's go through this algorithm. If you have a female patient with a positive HCG who is hemodynamically unstable, you perform a FAST exam and the FAST exam was positive, you know that this patient needs immediate resuscitation with fluid, type and cross match, as well as blood and gynecology consult. If the patient is hemodynamically stable and has a history of IVF, immediately call GYN because these patients are at higher risk. Otherwise, you can perform a transabdominal ultrasound followed by a transvaginal ultrasound if your transabdominal ultrasound was not definitive. If you find by your ultrasound there is no IUP seen and there is a large amount of pelvic free fluid or a pelvic mass, you can perform a serum beta-HCG, and if the serum beta-HCG is less than 1000, a formal consultation, but likely there will be discharge with 48-hour follow-up arranged as well as ectopic precaution given to the patient. However, if the beta-HCG is greater than 1000, formal ultrasound is obtained and the gynecology consultation. So if you perform your bedside ultrasound and you see a positive IUP seen, you can discharge them home with an obstetric follow-up. So what are the ultrasound findings of an ectopic pregnancy? Transvaginal ultrasound can detect the embryo in an ectopic pregnancies, the presence of adnexal mass or fluid in sac in a patient with no intrauterine gestational and a measurable circulating HCG is highly specific for diagnosing ectopic pregnancy. The absence of sonographic findings of ectopic pregnancy does not exclude the diagnosis, because up to 30% of women with extrauterine gestation have no sonographic evidence of adnexal mass or pelvic intraperitoneal fluid. I want to emphasize that the goal of bedside ultrasound is to identify a definitive IUP. Because once you identify a definitive IUP, you can rule out ectopic pregnancy with 100% negative predictive value in low-risk patient for heterotopic pregnancy. This is a patient with pelvic pain and positive beta-hCG. I know this is a transvaginal scan, but I just wanted to share this case. So is there a definitive sign of IUP? And the answer to this question is no. I will freeze 2 clips from this video, and you can see that there is the endometrial stripe and uterus, and you don't see a definitive IUP within the endometrial stripe. While the image on the right represents that there is an extrauterine circular structure concerning for an ectopic pregnancy. So that's why, and this can be mistaken for an IUP. Therefore, I can't emphasize more on evaluating the IUP and making sure that it is in the middle of the endometrial stripe. So the majority of ectopic pregnancy, almost 95% of them, occur in the fallopian tubes. Ovarian, abdominal, cervical ectopics are rare. However, these non-fallopian tube ectopics carry a higher risk of mortality because they rupture at a later gestational age, and thus hemorrhage is more rapid. Don't forget the myometrial mantle distance. To prevent mistaking a cervical or corneal ectopic for an intrauterine pregnancy, one must determine that the myometrial mantle thickness is thick enough. The thinnest stripe of the myometrial mantle seen and surrounding the gestation should be measured. Anything less than 8 mm is concerning for a cervical or corneal interstitial ectopic pregnancy, and proper consultation should be arranged. Here are some examples of other findings you might encounter while performing a transabdominal pelvic ultrasound. So in this video, you can see a subchorionic hemorrhage. There is anechoic fluid separating the gestational sac from the myometrium. These patients should pursue formal consultation because they are at a higher risk of hemorrhage and miscarriage. This is another finding that you might encounter. And this is a twin pregnancy. Another possible finding is this molar pregnancy. You'll find large uterus filled with heterogeneous material in form of hundreds of tiny follicles because a significant number of such patients have high HCG levels and undergo malignant transformation of the tissue, and they should pursue formal consultation. This is another possible finding which represents an intrauterine device for contraception, and it is a reverberation artifact seen in the middle of the endometrium. The placement is normal, which is the mid-uterus at the endometrial stripe. Let's review some literature on how good are emergency physicians in first trimester ultrasound. Studies of emergency physician performed ultrasound in this setting have demonstrated the sensitivity of 76 to 90% and specificity of 88 to 92 for the detection of an ectopic pregnancy. In one study, emergency physicians were able to determine an intrauterine pregnancy in 70% of patients with suspected ectopic pregnancy. When an intrauterine fetal anatomy was visualized at the bedside, ectopic pregnancy was ruled out with a negative predictive value of 100%. There are other important parameters that we care about. Most importantly is the length of stay. And there are some studies that have shown that performing bedside ultrasound to evaluate for an intrauterine pregnancy have reduced the ED transit time. So in summary, all patients with positive beta-hCG and a pelvic complaint should be evaluated with an ultrasound. There's no beta-hCG level at which a patient can be ruled out for an ectopic pregnancy. And remember, the goal of performing a transabdominal pelvic ultrasound is to identify a definitive IUP. The signs of a definitive IUP include identifying a yolk sac, a fetal pole, a fetal heartbeat. And once you identify a definitive IUP, you can rule out an ectopic pregnancy with a negative predictive value of 100% in patients who are low risk for heterogeneous pregnancy. Thank you for your attention. Keep practicing and keep saving lives. Here are the references I've used to prepare this talk.